Okay, so we're now going to get started, and we've done our quick start and the menu has come up, and I'm going to select Iliac and SFA interventions, and within the menu that comes up then to the right of that, I'm going to pick up Ipsilateral common iliac lesion, and the Mentis then takes a few seconds to start up. And the first thing, we would have already positioned a sheath after placement of a micropuncture needle into the common femoral artery, and ultrasound nowadays is very commonly used to look out for calcifications and make sure that the access point is above the femoral head as well. And this is particularly important in patients who've got iliac disease and may have severe calcifications along their entire iliac system. And obviously, if you intend to use a closure device, making sure that your access point is away from any significant calcification is important, and that can be assessed with ultrasound, in fact. So once we've got our sheath in, and anticipating from the CTA that we will be doing an intervention, typically a 6 French sheath would be positioned, as this will accommodate any potential for stenting should a stent be used, but typically we'd intend to do an angioplasty for most iliac interventions. Obviously, attention to the detail on the CT angiogram will help predict what's required, which includes the diameter of the balloon as well. And in this particular case, this is a gentleman apparently who has a claudication at about 100 yards, and we know from his CT angiogram he's got a common iliac stenosis. And the vessels proximal to it measure approximately 10 millimeters. So through our 6 French sheath now, we're advancing a wire and a multi-purpose catheter. That's a catheter with an angulation at the end of it, so that could be a hockey stick, a Compi catheter, are commonly used. And these are end-hole catheters through which we're passing a curved hydrophilic wire. So on our Mentis system, then we pick out the inventory that we want to select, and there's a get device, and then you can see that there's a selection menu. So I'm going to pick a 035 hydrophilic wire is best, and with a 3% flexible kip with a 30-degree angle, and 180 centimeters is certainly long enough for this sort of an intervention. 150 would do you as well. And then I'm going to pick out a catheter. I'm going to use a 5 French diagnostic catheter. And to get past the stenosis, I'm going to use a selective catheter. And as I said, I just want a gentle curve. So you can see on the menu, you can roll down through the different catheters, and a picture is presented to you of the shape of the different catheters. So we're going down through Cobra there, and the shepherd's hook, which we definitely don't need for this, which I've accidentally pressed. So I just want just a gentle hook catheter, such as a multi-purpose catheter. And you could just as easily use a straight catheter, in fact, for the iliac system. But sometimes you will need a bit of angulation in your catheter to help you transgress a severe steno-occlusive disease, or indeed an occlusive lesion. So we'll just select that multi-purpose catheter, and we've got our hydrophilic wire, and so we'll get started now. So I'm going to scroll down to the level of the lesion with the assistance of fluoroscopy. And at all times trying to pay attention to trying to limit the amount of radiation to the patient by coning in, using the cones appropriately. So the first thing we're going to do is advance our wire through our multi-purpose angled catheter, and put the curved hydrophilic wire along this catheter up to the level of the presumed occlusion or stenosis. Now at this stage we only know what we know from the CT angiogram. You can see there the catheter held up on a stenosis, and that's an indication of roughly where the stenosis is. The wire has transgressed the stenosis, and now I'm going to advance the multi-purpose catheter along the wire, being careful not to advance the catheter bareback, it's always traveling over the wire. And so now I believe that I'm central to the stenosis, so I'll pull out the wire, and the first thing I want to make sure is that I've got re-entry into the proximal lumen. So now to check that my wire has passed into the proximal true lumen, I'll do a little test injection to be sure that I'm intraluminal, and that clearly is intraluminal with good flow in the distal aorta going into both iliac vessels. And the next stage will be to do a diagnostic study. And for that I'm going to put in a pigtail multi-site hole catheter. So again, I'll advance my wire, which can be the same curved hydrophilic wire which I'll use for the rest of the procedure. So I'll remove the multi-purpose catheter. And then I'll go back to my laptop and I'll select the catheter that I wish to use, and it's a 5 French flush catheter. Doesn't have to be any longer than 60 centimeters, so 5 French 60 centimeter long pigtail will be perfect. And I'm going to advance that now into place. And there's the pigtail. Now I'll remove my hydrophilic wire, and there's the pigtail forming, and I'll pull it down to the presumed area of the distal aorta. I'll remove my wire. And now I want to make sure that my positioning is appropriate for the iliac vessels. So I'll do an AP examination. I'll widen out my cones a bit, and also I'll introduce some angulation to open out the branching point of the at the iliac bifurcation. So consideration for the diagnostic angiogram include obviously the injection rate and the amount that we're going to inject, and I've picked out 10 cc's per second with the pigtail in the distal abdominal aorta for a total volume of 20 cc's. You would typically use full strength contrast at this location. For infrainguinal diagnostic DSA angiography, you can get away with using half strength contrast, but for this particular injection we're going to use full strength contrast. And there you can see a nice angiogram of the distal aorta showing that there is a significant stenosis at the mid-right common iliac level. The significant stenosis is going to be any stenosis above 50%, because we know that that's associated with a reduction in flow of at least 75%. So now we'll do some measurements. We already know in the old days they used to put calipers on these angiograms to measure up the diameter of the normal vessel to estimate what size the balloon you would use, and typically they'd oversize about 10 to 20% in the old days going off the angiographic information. Now though with CTA you do exact measurements from the vessel, from the CTA, and from this patient's CTA we know that it's roughly a 10 millimeter proximal common iliac vessel, so a balloon between 8 and 10 millimeters would be appropriate, I think, in this case. So having done our diagnostic angiogram and having decided that we're going to do a balloon angioplasty of the common iliac with, I think, a 10 millimeter balloon, we'll advance the wire and remove our pigtail catheter. Now, this is a time when you might consider medications that you might administer, such as heparin or vasodilators. Most people now wouldn't administer heparin. The rare exception would be if, for example, your sheath was across a calcified or it's a stenotic disease of the external iliac, and when you did your injection, there was hold-up of contrast at the sheath level. In that situation, you might consider giving heparin. Typically, though, heparin is not administered for iliac interventions, as the vessels are big enough and the flow is adequate enough to prevent thrombosis. Vasodilators are also very infrequently used, and certainly it's not part of my practice for iliac interventions, whereas it would be the case for infrainguinal interventions. So the next step is to pick out our balloon, and I think we decided that we were going to go with a 10 millimeter balloon. So you can, over a 0.35 system. And so I think, again, also from the CT angiogram, we know that this is roughly a 2 centimeter long stenosis. So I'm going to pick a 40 millimeter length balloon and 10 millimeter in diameter, and the balloon is rated up to 14 atmospheres. So now, marking the level of the angiogram, most people would use anatomical markers from the DSA. So I'm going to pick out a roadmap images for the purposes of determining the level of the angioplasty balloon inflation. And so that's a satisfactory image. And then we'll make our roadmap, as you can see, and then I press X-ray. And that gives us an image there, nicely showing the level of the stenosis. As you can see, this is at the level of just below the end plate of L5. And once we make sure not to move the image intensifier, and obviously making sure the patient doesn't move as well, that's a good secondary indicator as to the level of the balloon. So now we're going to advance our 10 millimeter by 40 millimeter balloon over the hydrophilic wire that has been in place since we removed the pigtail, and here comes our balloon across the stenosis. And then you can either use hand syringe or an insufflator device to fill the balloon. And we're going to gently, remembering that the balloon is rated up to 14 atmospheres. The balloon's slowly starting to, we're up to 6 atmospheres there, 8 atmospheres, and we look as if we've got our nominal diameter there at 9 atmospheres. The time of insufflation varies between different operators. Most people would leave the balloon up for at least 30 seconds, I believe, deflate, and then quickly inflate a second time is my standard practice, depending on how easy it is to get out to the nominal diameter. So that you prefer always to try and get the balloon to get out to its nominal diameter, as shown in this particular case. So roughly after 30 seconds or so, I would deflate the balloon. Side note, if you're having difficulty deflating a balloon, use a bigger syringe. Use a 20 or even a 50 cc syringe will be better at sucking the dilute contrast out of the balloon rather than a smaller syringe. Again, the other emphasis would be on making sure that you don't put in full strength contrast into the balloon. Typically just half strength will be adequate. So then I would just very quickly insufflate again and just let down the balloon again is my standard practice. But again, there are multiple ways of timing the insufflation, and indeed the number and duration of balloon inflation varies tremendously between different operators. So having ensured that the balloon is fully deflated, we'll take the balloon out, and then we'll reintroduce our diagnostic catheter. So that was the pigtail catheter, the 5 French pigtail catheter. So we're reintroducing that catheter now. We're just bringing the pigtail catheter down to the distal aorta for our repeat injection. Now we're going to take away the mask, the roadmap at least, and we're going to pick our injector. We're going to use the injector again, similar rate, a rate of 10 cc's per second for a total of 20. We're going to do the injection now. So morphologically, that looks like a very good result with good flow through the stenose segment. There may be a situation where there's an equivocal residual stenosis, and pressure measurements can also be measured. Typically, a systolic gradient of 10 millimeters mercury is considered significant. If you're doing measurements, pressure measurements, most operators, I think, if it does come to that situation, will also give a vasodilator such as nitroglycerin, which is the equivalent of an exercise test, and will exacerbate any significant gradient that may involve a so-called significant stenosis. But with vasodilators, you'd expect the gradient to go up to at least 20 or even 30 millimeters mercury before we consider significant. In my practice, we very rarely use pressures nowadays. I used to use them a lot in years gone by. So it's really only in a situation where we're considering using stenting, or where we've put in a stent, in fact, and there's a residual stenosis that we're wondering about going more aggressively with a balloon in a situation where there's circumferential calcification, where you want to be that bit more careful about using higher diameter balloons because of the risk of rupture, even in a stented vessel. So this is a very satisfactory result of a common iliac angioplasty. So at this stage, we'd remove the diagnostic pigtail catheter again over the wire, the hydrophilic wire that we used initially, and then use a closure device for closure. So the catheter is out now, and then I can pull back my wire and start my closure device procedure.